Salters, his hips aren't bending where the bed is bending. See how he's all slumped down? See how he is? So he needs to really sit up. Come on, guy. Careful, he doesn't pinch you because all these mannequins do. That style person should look when their head of the bed is up. Mr. Salter's head of the bed up 30 degrees. If he's up 50, he's up definitely high enough. All right. In this quarter, we are not teaching you insertion of a nasogastric tube. We'll do that when you study GI, but it's not too tough, so we can talk about it. But we'll do that procedure later. Is it a sterile procedure? You know, like...
Yes. Because going in?
Well, no, because it's going down the GI tract. Nothing in the GI tract is sterile. Okay. I haven't noticed you eating any sterile foods. Maybe. Okay. So... and the technique would be that we would get an appropriate size tube. This is that French sizing of tubing we talked about before, where it's the number of millimeters on the outside. So as the number of a tube gets larger, you know, if it's a 14 French or an 18 French, as the number gets larger, the size gets larger as well. All right, so, and we'll see that we have to measure, it has to be less than half the diameter of the nares. That makes sense. We want them to be able to breathe around it. The technique is we measure from the tip of their nose around their ears to the xiphoid process and mark it. We could roll it in some Surgiloop, some water-soluble lubricant, and then in order to go up the nares and in through the passage at the back, by the sinuses, you know, it's not like the tube's going to go up and then turn a corner for you, right? So what you do is you actually pull their nose up so that you make it a straight shot. And what's going to happen when you get to the back of their throat and touch them in their oral pharynx? They're going to go, right? If it was a person who was getting a tube like this, is a sump for decompression or drainage, and he was cognitively intact and could actually drink, we could actually hand him a glass with a straw in it, and once he gagged, we could say, all right, swallow, 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 and so on. And so he could go, we'd say, all right, drink out of your straw, swallow, 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 and this tube would just go down like that with down into his stomach. This is not a painful procedure. When I was in nursing school, we had to do this to each other.
You do
that quick. It is that quick. It needs to be that quick. You need to get past their airway and get on with it. So you just go like that in a second or two.
So we're not doing this to each other?
You're not doing it to each other. No, you're not. We don't do that for liability more. But we used to do it, and it wasn't painful at all. It's a little on the noxious side.
It said that something about past the xiphoid process. Was that for, like, deeper ones?
No,
on HGI it said, I swear the answer said like 20 to 30 centimeters beyond the xiphoid process, and I said that sounds way too nuts. Is that a deeper?
2 centimeters or 20?
No, I swear it said 20 to 30 on HGI.
Was that for a jejunal tube?
Maybe that's why I'm asking.
Yeah, that seems kind of interesting.
That's why I'm asking.
All right, so once my tube is in place and he's done that, see how it's secured to the nose so it won't be dislodged. I really don't like using white tape. Put a piece of white anything on your nose and walk around for a day. You will have a profound headache. So most hospitals use a flesh-colored thing so it kind of fades in. It looks a little Band-Aid that looks like a butterfly, and it pinches on the nose and then pinches on the tube. But I really like the way this has been taped, because this is the other way to do it. And I just want to show you. Remember we talked about when you're opening tape that you would curl the edge of the tape to make it easy to get out? Well, if you put this tape flush on there without any way of peeling the tape off, then it's going to be really sticky. You're going to have a hard time. But there's a flesh color tape. Sometimes what I do is just take a regular Band-Aid and I just cut up to the little pad and I put the Band-Aid part on their nose, curl the edges like that, and swirl this around, and so it won't become dislodged. All right. So this particular tube is a Salem sump. This is a tube intended for what? Gavage or lavage?
Lavage.
Lavage. This is for washing. All right. So it could be that I have this patient on suction because they've been vomiting, and there's no point vomiting 8 million times a day, so I could actually just put this on low. This one's on low continuous suctioning. And this particular tube is that 2 lumen. If you did a cross-section, you can see there's 2 plastic. All right, there's 2 holes. There's 2 tubes going down there. And this one leads to this. This is air. That's how it creates a sump action. As it's sucking the stomach contents up this tube, it's pulling air down there to allow it. Otherwise, it would just suck up against the stomach wall. The minute you turn the suction on, nothing would come out and nothing would happen. So when a Salem sump is functional, you should be able to come along. You should see stomach contents going up into the tube, just like that. Wow. Does he really have stuff in his stomach?
I guess sometimes water.
Cool. That's very cool. And I should be able to hear air coming out of here, which I actually don't. But you should hear. Oh, that's very neat. All right. So it's just like that. You should see, even if they have very little, you should see at least residue or something coming up that particular tube. No, you can't. You, Patrick, no. Or you can't. And so that's just a Salem sump. Notice how they secure it somewhere. And I usually put it, this is what it looks like more like this all the time, is you see constantly air coming up. If you don't see any movement of something coming up that tube and you don't hear air, it's sucked up against the stomach wall. And so you can do one of a couple of things, which is
running out.
Yeah, this is how it normally looks, all right? This is how it normally looks. So one thing I could do is I could actually put some air into it to blow it away from the stomach wall, all right, and then hook it up and see if it works. Or I could pull up some water and put some water down there, all right, and hand irrigate it and then hook it up to suction. Anything I add as a volume to this, though, I'm going to have to record as intake somewhere because we're going to be looking at the output, right, because we're taking away some of their body fluids by doing this, and we're going to have to wonder about replacing those, so on. So keep that in mind. So that's how a Salem sump works, and usually what I do with them is just I put them in a towel and I put them up under the pillow or one of those, remember we have those flat sort of chucks like diaper things to keep the bed dry, just because it is a gravity drainage system, and then this way it keeps it out from their arms and everything so that it doesn't accidentally get dislodged. Okay. Let's say that this person is no longer to suction. They have good bowel sounds. They are passing gas. The physician does want them fed now. And so they've asked us to convert this to a feeding tube. Feeding tubes are single lumen tubes. So one thing nurses do is just make a knot in this thing. We may see somebody like that to tie this off, and now we could use this for a feeding portion. And here's another feeding tube. So did we look at these last week at all?
No.
Okay. So this is the one called Levine. All right. Remember? You know, but it's just a feeding tube. And all it is a single lumen tube. Right? Just a plain, there's no fancy pigtail, none of that. This one would never work for suction, could only work for feeding. And these tubes are weighted tubes. It's all very exciting how they wrap that up. And weighted tubes can pass to the duodenum or the jejunum with peristalsis. All right, just use this one, Jane. Thank you. I think I will. Okay. All right, so this one, and these are called small bore tubes, all right, and they have different brand names. And what they were able to do is, as plastics, the ability to work with plastics has improved. You don't need such a big tube. See how tiny the inside of that is? Do you see what I mean? Most of this tube is the outer wall. Mm-hmm. So a small bore tube, what's neat about it and what they've been able to do is by making a plastic that's thinner walled, they can have a great lumen on the inside. So, and this one has a weight on it. See how that says little weight? It's like tungsten in a plastic. And so it's like a fishing weight or something, huh? And it would just come down with, you could just come down, yeah, with peristalsis. And notice how soft this one is. I mean, it's not like having this thing, feel the difference in the flexibility. So this one long term isn't going to irritate the back of somebody's throat and all that other kind of stuff. These tubes, the ones that they use for long term feeding tubes. But this tube, in fact, is the one that has caused the greatest problems because it is so floppy that in order to put it down somebody's nose, it's just not going to go where you want it to go. So the way that these are placed is it has a stylet. It comes packaged with a stylet, which is like a long metal needle or probe or something like that. And